Hi, welcome to your checkup. We are the patient education podcast where we bring conversations from the doctor's office to your ears. On this podcast, we try to bring medicine closer to its patients. I'm Ed Dulesky, a family medicine doctor in the Philadelphia area.
And I'm Nicole Rufo. I'm a nurse.
And we are so excited you were able to join us here again today. So we're recording from a very special location with a quasi-live audience staring at us here, who is not just our intern.
Place. Yeah, we have our intern who's also accompanied by... Does she have a title? Our HBIC.
Yes, by the HBIC and a crow upstairs who is not watching. We're driving down
we have a live audience.
We do. This is the first time we've had a live audience. This is quite the honor. And we're just looking forward to putting together a great episode here today. I hope this isn't so echoey that this is prohibitive.
Well, I guess we'll find out.
We're going to find out. So we're driving down the highway, and we see a large bulletin board. A bulletin board? What is it? Billboard? Billboard. Thank you.
Board.
Live audience already contributing.
Our live audience.
We see a live a billboard that says, "Give space to the seals." Why do seals need space?
We all need space. I feel like I relate to the seals sometimes.
Yeah, you needed space earlier today.
Yeah, I did.
Yeah.
What about it?
Well, if anyone out there knows why seals need space, if they thrash about and offer...
They might be aggressive.
Oh,
valid.
That they're sunning on the beach.
Yeah,
and
our
don't
live
want to be
audience.
disturbed.
Yeah.
Yeah. Perhaps that's it. Well, if anyone out there has any better idea about why seals might need space, please let us know. And maybe they're sunning on the beach. My second point I wanted to raise today is the movie Nonas.
Oh, yeah.
What a wholesome movie on Netflix. If you haven't seen it, go check it out. Vince Vaughn is this guy whose mother passes away. Enoteca Maria, right? I think that's her name.
Yeah.
And he makes a restaurant in her name as an homage to honor her and her Italian recipes. And he hires Nonas to be the chefs. It is an incredible movie.
Eddie feels seen. He feels that his culture is represented on TV.
Finally, my upbringing as an Italian grandmother has finally been recognized. No, but truthfully, I think they did an excellent job of really putting these women to the forefront and celebrating them. And it was a great, wholesome, family-friendly movie. He
may or may not have teared up at the end.
Wouldn't you? It was so beautiful. He was getting ready to... Well, I don't want to spoil it for anyone, but it was an amazing movie. And... Well, they said all the hot phrases. Like they said, oh, maron, or that's a sin, or they talk about this what was it? The head of the beast that they said, the capuzel. Mm-hmm. But what was the animal?
A sheep head.
A sheep head.
Yeah.
Yeah, and apparently you can go to this restaurant based on a true story, and we can talk about the true story thing that I've had. Otherwise. Mm-hmm. Well, I didn't know that The Blind Side was a true story.
Are you for real?
Yeah, I think.
When did you learn this? You didn't know?
No. Like it was only after watching the movie that it became apparent to me. But I went the whole movie experience thinking it was a fictional movie.
Oh.
With Sandra Bullock.
Yes.
Yeah. So that was real. Unbeknownst to me. So I've known it since the movie came out, though.
Oh, okay.
Yeah.
That's less offensive.
Do you have any takeaways from this week of anything that you were hoping to talk about a little bit?
Do we need to talk about your toilet incident last night?
Why don't we do it? Why don't I see how I feel? This was an outrageous thing. It's not every day you go to the bathroom, and sometimes you have different experiences. Some are loose. Some are live audience members saying, you don't go to the bathroom every day. If you have a busy morning and you're running out.
Sometimes you suffer from occasional constipation.
Yeah.
And we have an episode on that.
Right. And you can go listen to that if you want. So, I'm doing my business. We have the Squatty Potty. If you haven't heard or understand that we do that, we have a travel one. So I'm like hanging out with the travel squatty potty. And like, it's a larger one. The girth is bigger than normal. And I understood that on the way out. And I give it one flush. And the water's a little slow to go down. And so I think, maybe it needs a little bit more flow to kind of break it up. So I give it a second flush. And the water level rises in the toilet. And now I'm an idiot because I'm looking at it and I'm like, a third will do it. Third time's the charm. So now the bathroom door's open. Nikki comes up and she's looking around. And you come into what? What do you see? Like from your perspective.
It was probably one of the funniest things I've ever seen. He's hunched over the toilet with like the toilet seat up and the water's overflowing.
Now it's overflowing.
It's all over the floor. And my parents are downstairs. And he's like, this is so bad. I need it. Do you have the plunger? Do you have the thing? I need it now. He's like, don't tell them. So I run down the stairs and I'm like, Eddie clogged the toilet. I need the plunger. Where is it?
And you're like, do you need me to go get go get my dad? Like, do you need me to go? I'm like, no, do not. I do not go get him. No, I need to fix this. Do not. And it's about 5 minutes, and we're like right at the cusp. Like the water is at the top of the toilet, and then like we hear from Mary downstairs, and she's like, "Just click the button in the reservoir, and the water will go down." So then you come in. Thank you for saving the day. You click the button, and the water starts coming in again.
Yeah,
and now we're getting even higher and higher, and I'm like, "Oh, we're overflowing again." Now the towels are on the floor. The thing was a very clean thing. The turd was like down the pipes already. Like this was a downstream obstruction. And God bless if this makes it like live to the episode. I mean, this is gonna be crazy. Eventually it worked out and the plumbing works. And that was a beautiful thing that happened. It was, yeah. It was. I think it was, yeah, that's that.
Oh, man.
How do you feel? Anything else you want to talk about? I think that was...
I don't think so.
It's about 7 minutes. Oh, yeah, wait. And so then you come back and I'm like, can you get like a wire hanger or anything? And I'm like, I need a wire hanger. And I'm like, I need something metal. And she's like, okay, let me go look. So she comes back and she's like, we only have this. And she comes back with a routine plastic coat hanger.
Okay, we're not a wire hanger family. We're a felt hanger family. And a couple rogue plastic ones.
And I'm like, why did you bring that? And she's like, this is all we had. It's not a comedy podcast, but I hope that you get some jokes out of it every once in a while. This is a good opener. Yeah, it was good energy, live audience.
Man, I hope Mike laughs at this when he's in his basement doing basement things.
I can't believe that like potential future patients of mine listen to this and maybe they'll get a sense of my character and bowel habits.
Hopefully.
All right, you ready?
Yeah.
All right. What are we going to talk about today, Nick?
Today we're talking about prediabetes.
Yeah, this is such an important episode, and I really want to call light that this episode fills the gap in this type of situation. You went to the doctor. You had a nice visit with them. They decided to get some labs. And they said, I'm just going to get some labs to do some metabolic studies. And then you get the results back. And they give you their interpretation. And they give you a little one line. Or you see a little thing like hemoglobin A1C 5.8. And they send you a message and they say, sorry, we detected that you have prediabetes.
Good luck.
Do some diet and exercise and see you later. This episode, I hope, fills this gap because that is such a common thing that happens. This whole thing is so common, in fact, that it's estimated, because there's a thing here, is that it's estimated that more than 96 million Americans, that is over 1/3, 1 in 3 people have prediabetes, and as many as 80% of people don't know they have it. Just sit with that for a second.
Dun, dun, dun.
Dun, dun, dun. But really, like people are floating around out here with pre-diabetes, not knowing it. Now, this wasn't a thing like forever. Like like when I was in med school, some doctors were like, pre-diabetes wasn't a thing back in my day. But it is now. So that's why we're going to talk about it here today. So pre-diabetes doesn't only increase the risk for getting diabetes itself, it independently has risks for heart disease, stroke, and kidney disease. And so today we're going to inform you and empower you with facts, tools, and hopefully by the end of it, some hope. Nikki, can you take us through and tell us what is pre-diabetes?
Prediabetes is, the explanation's pretty simple. It's when our blood sugar is elevated. So it's high, but it's not high enough to call it diabetes.
To capture the diagnosis of prediabetes, the American Diabetes Association in 2025 says that you need a fasting plasma glucose. What does that mean? You haven't eaten in 8 hours and you got your blood work done and you have a blood sugar between 100 and 125 milligrams per deciliter. And I have to correct myself because we have an international audience that is not the millimole number. So that's just the American standard numbers reported. You can have a 2-hour oral glucose tolerance test, which is less common because it's kind of cumbersome. You have to drink a glucose solution and then get your blood sugar measured 2 hours later. But if you do that and your blood sugar is measured between 140 and 199 milligrams per deciliter, they call that impaired glucose tolerance, as opposed to impaired fasting glucose, which is a different story. And most commonly, I would say, comes up the hemoglobin A1C, which we'll restate is that 3-month average of your blood sugar that, when blood sugar plucks on your red blood cells, the lifespan of a red blood cell is about 90 days or 3 months. So it's like the 3-month report card of your blood sugar. And if that level is between 5.7 and 6.4%, that is prediabetes. And it's important to know that many people feel totally fine. They don't feel sick. And that's why this is kind of like a yellow flag, a silent warning that happens. So, Nikki, we talked about like the diagnosis and how you capture that, but who is at risk for prediabetes?
So people who are 45 years or over, anyone who's overweight or obese, so with a BMI of over 25 or 23 for Asian Americans, family history of diabetes, low physical activity, any history of gestational diabetes or PCOS, high blood pressure, and then certain racial groups, so Black, Hispanic, Native Americans, Asian American, and Pacific Islanders are more at risk.
Yep. And there are certain tools available, like the American Diabetes Association has a risk test. So this is a simple online self-screening tool. And truthfully, like if you could, I think there are different guidelines from different groups that make these guidelines, like the USPSTF or American Diabetes Association have different opinions about who should get screened. So essentially you should ask your doctor about what the right plan is for you.
So before we get into what we can do about prediabetes, let's talk about why it's important.
This is going to be a bigger conversation, so kind of buckle in for this one. The risk of diabetes is something I want to spend more time on, so I'm going to start with the other ones. Prediabetes itself has been described in the literature that there is an increased risk, independently of anything else, of heart attack, stroke, and chronic kidney disease just by having prediabetes. So that in and of itself makes it important enough to pay attention to. And oftentimes, people, when they have prediabetes, also may have hypertension, or they may have dyslipidemia or otherwise abnormal cholesterol levels. And they may have central obesity, which that visceral fat, that fat that lives around the belly, is worse compared to other types of obesity and subtypes. So then the big question comes of, I have prediabetes, not me, but someone like a supposition saying like, I have prediabetes. What does that mean for me? So there's a lot of literature that says that the annual progression, that there's about like a 5 to 10% risk every year of developing diabetes when you have prediabetes. There are European studies that try to estimate lifetime risks, but you can imagine that that's a little tricky because someone may be 20 with prediabetes. And then you might have someone who is 70 who discovers that they have prediabetes. And those two people are in different risk groups. So there's a European study that states that the lifetime risk of developing type 2 diabetes for someone with prediabetes is 74%. Now that's pretty high. But I think that doesn't really totally like calculate that like someone who's 20 years old has like an 88% chance of developing diabetes if they have prediabetes. So to sort of round that up and summarize it, if you have prediabetes, every year there's about a 10% chance of developing diabetes. And in a lifetime, there are lots of different studies, and it matters how old you are, but it could be 74%, could be as high as 88% in the lifetime if you don't take action to prevent that now. Does that invoke any feelings or thoughts? Did you know that, like off the dome or?
I mean, not those specific numbers, but I feel like that's important to know because I feel like people are told they have prediabetes and then they're just like, oh, well, I don't have diabetes.
Right. And it matters. Like we're going to talk about like medicines in the like later parts of the episode, but like there are high risk prediabetes groups. Like if you're over 6 or you're younger, that's a much higher risk, or your BMI is over 35, like much higher risk of developing diabetes than someone without those things. We're going to save a little bit of that conversation for after, but that's sort of why this is important because it affects your heart health, stroke risk, chronic kidney disease risk, and overall the risk of developing diabetes is significant. So why don't we take a little bit of time after like being a little doom and gloom of like, oh my gosh, I have prediabetes. You probably now have thought more about prediabetes if you're making it this long through the episode than you ever have before. But what can we do to prevent progression to diabetes and kind of manage those other risk factors?
There are a lot of things that we can do. And we actually have multiple episodes on all of these things. And that's because, well, medication aside, all of them are lifestyle changes, which are the cornerstone of prevention.
Totally. So this data isn't just pulled out of thin air. There were massive studies that were done and continue to be done. But a lot of this data that I'm going to say next comes from a very large study called the Diabetes Prevention Program. And that showed, and I'm going to give you very specific numbers here because I think when we talk about goals, we like to have something like a SMART goal. And this falls under the S of that specific. Losing just 7% of your body weight and entertaining or doing 150 minutes of moderate intensity exercise a week reduced the risk of diabetes by 58%. Just those things. So a 7% weight loss that can be challenging to get, but it's not insurmountable. Mm-hmm. And we can talk about how they did that, but that's what they found. That study was done over the course of 3 years. So there's like a little bit of a limit to that. And another piece is that you even get some benefit even if you don't lose weight and you just exercise. They also looked at people who didn't lose weight and they just did physical activity goals. And that cut the risk of diabetes by 44%. So even if you're just moving and you don't lose any weight, it's still worthwhile to do exercise. And we've talked about like why exercise is so important beyond weight loss or anything else, like improving your sleep, improving your mood, your cognition. Now here's another reason. So what else they did, how do you, like we've talked a little bit about this in other episodes, but to kind of like talk about how they lost weight in this study was they looked at the amount of calories that it took someone to stay the same weight. And they found that out just like in their diet, tracking what they ate. And then they subtracted 500 to 1,000 calories a day. And then they went for 700 calories a day of physical movement. And so in creating that, they were able to induce this calorie deficit and help people lose their weight. And so we have a question from our audience here of what does 700 calories look like? And because that's a challenging thing to capture, they translated that into 150 minutes of moderate intensity exercise a week. Oh, yeah. And so otherwise that translates into 30 minutes 5 times a week. And to the weight loss end, since we were talking about that a little bit, there also was evidence from the diabetes prevention program that said for every kilogram of weight lost, so for our overseas folks, congratulations, we're using the metric system. For those in the United States, it's about 2 pounds. For every 2 pounds lost, there is a 16% reduction in transition to diabetes over the course of the 3 years. Just to give you a little bit more. And they saw more was better in terms of like 10%. If you lost 10% of your body weight, great. Even more benefit, less risk of developing diabetes. So we talked about weight loss. We talked about physical activity and their role in reducing the risk of going to diabetes. What about nutrition? Like, what certain things should we think about here? Or what opportunities are there for people to have their improvement? So in the study for the diabetes prevention program, they found that no single ideal macronutrient distribution worked. What the heck does that mean? No amount of carbs compared to protein, compared to fat, actually made a heck of a difference for preventing diabetes. And it has to be personal for that individual. But there are some effective eating patterns that are very well known to help prevent diabetes. And these include the Mediterranean diet, certain low-carb diets, and plant-based or the DASH diet. All are well known to help prevent transition from prediabetes to diabetes. And the key piece of this knowing is that you really just have to find what works for you. And so there are certain foods that we can emphasize. Nikki, can you take us through what foods, like we did on our prior episode, what foods to emphasize, and then what things we might be able to minimize as we think about food and the nature of preventing diabetes?
Well, we want to emphasize whole grains, nuts, fruits, vegetables, and our favorite, legumes.
And I'm not... Legume? Or legume? Anyway, and what sorts of things should we try to limit?
We're trying to limit refined and processed foods.
Yeah, also high in sodium oftentimes. And so for those people out there trying to watch their hypertension, that might not be helpful. There are certain scores I was looking up, there's the healthy eating index, the alternative healthy eating index, and the DASH score are all resources that you can look up online and kind of measure how good a food is if you're curious. And honestly, this is a great time for a dietitian to step in and help educate people because as you know here, we're listing a bunch of foods, but we don't talk about portion sizes. We don't talk about eating throughout the day and how to manage that. And honestly, they're so talented and it's a whole specialty in and of itself that gets its whole education. So we're not going to pretend this is the be all end all education, but it's something that you should think about because it's very important. Something else when it comes to, now we've talked about 3 things. We've talked about weight loss, physical activity, and nutrition. And the guidelines from the ADA specifically call out sleep in this year's recommendations for preventing prediabetes. And they now recognize that poor sleep is a key contributor of preventing diabetes. They highlight sleep less than 6 hours or greater than 9 hours linked to a 50% increased risk of diabetes.
We have to get rid of those blackout curtains here.
Yeah, I know.
You sleep like a teenager down here.
Totally. Yeah. I'm cozy. I'm a cozy boy in the morning. I just don't want to get up at all. And then
you're increasing your risk of diabetes.
By sleeping more than 9 hours. Yeah. I know. I didn't sleep more than 9 hours last night. And then they said that poor sleep quality is linked to about 40 to 84% increased risk. That's a big, broad range. So we'll keep it light there. But really, you should think about sleep hygiene. We have an episode on that. And stress reduction can be a really important part of preventing diabetes. So all those 4 things that we talked about are all things that you can start doing at home without a doctor. You just get outside, start moving, start exercising, maybe get a gym membership or find someone in your family, go for a walk after dinner, whatever it is. You can get started today. You don't have to wait.
Exercise, eat well, and don't watch reality TV before bed so you can sleep.
That's a crazy thing.
It's actually so annoying.
Yeah.
Like, I know we talk about like sleep hygiene and all the things that you can do, blah, blah, blah. We have a whole episode. It's like 2 nights this week, we watched TV in bed before we went to sleep. Both couldn't sleep. And then the following 2 nights, we didn't look at our phones and didn't watch TV before bed, and we slept the entire night.
Yep.
Didn't wake up until our alarms went off. So annoying.
I know, so annoying. And now we just watch our TV downstairs, and then when we go upstairs, we just don't. Because you got the whole projector thing, and it's nice. It's like big.
Yeah.
It's entertaining.
And our king bed.
I know.
It's a premium TV experience.
Yeah.
It's a sin.
So we spent a lot of time talking about lifestyle changes for prevention of diabetes. And we want to take some time to talk about when we think medication might help, because the American Diabetes Association does highlight certain times where it can be helpful. So metformin ends up being the most studied and safest medication used to help prediabetes or to prevent progression to diabetes when someone has prediabetes. It also happens to be one of the most common first-line treatments of diabetes as well. And Nikki, can you take us through a little bit of what makes someone higher risk when they have prediabetes of progressing to diabetes? We teased at them before, but can we say them out loud so everyone knows?
So people who are 25 to 59 years old have a BMI equal or greater than 35, have an A1C of 6% or higher, or a history of gestational diabetes.
Yeah, and the data on metformin is that it reduces progression to diabetes by about 31% overall in some quoted studies. And so if you remember when we talked about lifestyle changes and we talked about exercise, we talked about weight loss, there were significant changes. That was 58% over the course of 3 years. And you'll find studies that compare them head to head and say they're about equal. And so it's a personal choice, but that's just some of the data that we have. And truthfully, like, we listed those parameters, but metformin is more effective in younger adults and those who have obesity. A little note on metformin for anyone listening: long-term metformin use can lead to B12 deficiency and deserves periodic screening of that lab. Usually that increases with time, and the higher risk is seen 4 to 5 years after treatment. We have a lot of episodes, and we'll have more episodes in the future about other medications to help prevent diabetes. All of the medications that help people lose weight by way of accomplishing that weight loss of at least 7% help reduce the risk of progression to diabetes. But these include medicines like semaglutide, liraglutide, orlistat, which really isn't used much anymore, phentermine, topiramate, and the big gun, tirzepatide, otherwise called Zepbound or Mounjaro. And they show benefit very clearly. We don't have data for you right off the top, but I was listening to other podcasts recently that was quoting from experts like 95% reduction with the GLP-1 agonists in progression to diabetes. But unfortunately, these aren't FDA approved for specifically the prevention of diabetes, and honestly are really not covered by insurance often for these specific indications at all. And so metformin remains the easiest, most accessible, most affordable medication that could be used, and leaves room for conversation with your doctor. As we kind of get to the tail end of the episode here, I really wanted to highlight the opportunity to reduce cardiovascular risk. When people have prediabetes, now that's an additional risk factor. And oftentimes, like we said before, people usually have problems with their blood pressure at this point. They have problems with cholesterol oftentimes. And if someone's smoking, it is like a peak time to really stop smoking, because that is the worst of all for cardiovascular risk reduction. And if you were to really comb through the American Diabetes Association guidelines, and I think I might be opening a can of worms here, because apparently statins are a hot button topic. what they found in the diabetes prevention program was that the statin was associated with a greater diabetes risk. So it's real. It's statistically significant that they do slightly increase the risk of diabetes and tipping people over the edge when they have prediabetes. And so then they took that information and they compared that fact of like knowing that this happens and compared it against the benefit that statins have at reducing cardiovascular mortality and death. And the benefit of reduction in mortality is still greater than the slight increased risk of diabetes onset. And so then their recommendation is that you should still use the statin and you shouldn't stop the statin if this happens, which is a tricky thing because for some reason, they're such a hot button topic.
Yeah, people love to come for the statins.
They do. They're like one of the best medicines out there,
So weird.
the best medicines we have, and people love to come after them for some reason. And like anytime we're being active online, like this is the medicine that by far gets the most hate of any of them. And it's just crazy. So overall, the American Diabetes Association says discontinuation of statins due to concerns of diabetes risk is not recommended for people with prediabetes, which is a very nuanced thing that like I don't know anyone who would take the time in an office visit to explain. So then you get the people online with the highlight saying like statins cause diabetes.
Yeah. But like causing something and slightly increasing a risk for something are very different.
When like they knowingly already decrease the risk of death.
Yeah.
Making people live longer. So when it comes to preventing prediabetes, we talked a lot today. And we talked a lot today about like why it's important, what you can do to prevent it. The CDC is in flux in terms of how much we can trust their information with current administration changes and the Department of Health and Human Services. But there are programs. There are diabetes prevention programs that you can go out and ask your doctor for in the community. You can get some advice. Dietitians are out there. And go exercise. Go out there. Do whatever you got to do to be able to help prevent diabetes. So we have some closing thoughts, and they are that prediabetes is reversible, but you really do have to take action. And your health is worth the investment, and even the small steps that you take really do matter. So 3 things to think about are to ask your doctor if they think you should have your A1C checked. A brisk walk counts, so move your body. And try to eat more whole foods and watch your portion sizes and don't snack. So thank you for coming back to another episode of Your Checkup. Hopefully today you were able to learn something for yourself, a loved one, or
a neighbor with prediabetes.
Feel free to check out our website. Send us an email if you felt like you wanted to talk to us about this episode. And my one call to action for you is to follow the podcast so that you can see when our next episode comes out. And if you're really willing to take a step further, share it with a loved one or a neighbor, so that because 1/3 of them have prediabetes and they probably don't know it. So maybe they'll get something out of this episode. Most importantly, stay healthy, my friends. Until next time, I'm Ed Dulesky.
I'm Nicole Rufo.
Thank you and goodbye.
Bye.
This information may provide a brief overview of diagnosis, treatment, and medications. It's not exhaustive and is a tool to help you understand potential options about your health. It doesn't cover all details about conditions, treatments, or medications for a specific person. This is not medical advice or an attempt to substitute medical advice. You should contact a healthcare provider for personalized guidance based on your unique circumstances. We explicitly disclaim any liability relating to the information given or its use. This content doesn't endorse any treatments or medications for a specific patient. Always talk to your healthcare provider for a complete information tailored to you. In short, I'm not your doctor.
I am not your nurse.
And make sure you go get your own checkup with your own personal doctor.